I'm Todd Neal with MedPage Today at the American College of Cardiology meeting in New Orleans. Dutch researchers reported the results of a randomized trial comparing clinical outcomes in patients with atrial fibrillation who received usual care or care at a specialized Afib clinic. Dr. Robert Tielman of Martini Hospital in the Netherlands described the rationale for the study.
Atrial fibrillation is a very common arrhythmia, as you might know, and it's associated with high cardiovascular morbidity and mortality. And there are very solid guidelines which we should all adhere to in order to prevent mortality and morbidity. In 2005, our institution in Maastricht, the Netherlands, reported on poor guideline adherence in the Euro Heart Survey, which is a survey of more than 5,000 people all across Europe. And it was shown that whatever recommendation you take, adherence to this recommendation was approximately 60%. So we decided that should be better because it was also shown that if there was not a good adherence to the recommendations, then there was an increased mortality and morbidity.
To improve their patients' outcomes, Tielman and his colleagues decided to try a clinic approach, which was characterized by a substitution of care by specialized nurses guided by a computer program designed to guide treatment decisions according to published recommendations. Tielman detailed the process.
During the first visit, we invest a lot of time in gathering data from the patient. We have a protocolized diagnostic procedures. All patients get an echocardiogram, Holter monitoring, lab testing. They all fill out an extensive questionnaire. It takes them about half an hour, but it's their time, not our time. And all this data is put into the computer. During the same visit, the nurse informs the patient about the disease and its possible treatment options, possible complications. And after, like I said, all the data are put into the computer, and the computer comes up with a suggested treatment. The patient doesn't know anything about a computer, I should say. The patient just talks to a nurse. And at the next visit, the nurse and the cardiologist see the patient together. The cardiologist does not have to explain about the disease anymore because the patient knows that already, but he discusses the diagnosis, other things we have found, valve disease or uncontrolled hypertension or I don't know, and he discusses the treatment, the suggested treatment for the future and the treatment aims. That can be rate control, just lowering the heart rate, accepting the arrhythmia. That can be rhythm control, electrocardioversion, restoring the normal rhythm and give them antiarrhythmic drugs. And a very important issue is anticoagulation. A lot of patients need anticoagulation, about 80%, but not all patients need anticoagulation, and not all patients need the same anticoagulation. So after this second visit, where the patient knows what the treatment is aiming for, the cardiologist steps back and the nurse treats the patient according to specific rules, pathways in the software, and all under supervision of the cardiologist. But I do not see the patients anymore at that time. It's all being taken care of by the nurse. I think there are a few key issues in this way of working. First, we have a checklist. The software provides us a checklist. I do not have to fill out the checklist. The software does that automatically, but it pops up with things that I might have missed. Second, we go by the book. We follow the guidelines. Not that I know all the guidelines by heart, but the software helps us. And then third, we have like the pilot and co-pilot construction, because the nurse knows that I'm looking at him, and when I make a treatment suggestion different from what the software suggests, the nurse asks me, why are you doing that? And then I have to explain that, and if I do not have a good reason for it, I cannot do it. So I think that this pilot-co-pilot construction is also very important. And then the final thing is that the nurse spends a lot more time and gives a lot more information to the patient as that the cardiologists normally do. And I think that helps.
To assess the effectiveness of the approach, the researchers conducted a randomized trial of 712 patients, with half attending the clinic and half receiving usual care from a cardiologist.
The primary endpoint of the study was a composite endpoint of cardiovascular mortality and morbidity, and patients should be followed up at least 1 year. On average, the patients were followed up 22 months, and after 22 months, we demonstrate a 35% reduction in in primary endpoint, I should say, in the atrial fibrillation clinic, which constitutes of a 34% reduction in cardiovascular morbidity, less hospitalizations for cardiovascular reasons, and a 72% reduction in cardiovascular mortality. In the atrial fibrillation clinic, 4 patients died for cardiovascular reasons, and in the care as usual, 14 patients died.
Thielman said it was hard to pick out one aspect of the clinic that resulted in the observed benefits.
I think for outcome, better adherence to the anti-thrombotic guideline might be very important, because we see that in the care as usual, 7 patients die from thromboembolic events versus none in the AF clinic group. And there was a better adherence to the antithrombotic treatment guideline. So that might be very important, but it's very hard to pick out one reason and leave out the others. I think we only tested the combination, and I really think that the combination is very important.
Dr. Gordon Tomaselli of Johns Hopkins University in Baltimore agreed that it was probably a combination of factors that accounted for the benefit.
I also think that people that are involved in this program generally have better cardiovascular health. Maybe it's because they're more likely just because they're willing to participate in such a thing, but there is attention paid to not just the arrhythmia, but other aspects of cardiovascular health that probably have salutary effects on both rate and rhythm control and outcome in atrial fibrillation.
He said a clinic approach to atrial fibrillation could work in the U.S., where there's also suboptimal adherence to treatment guidelines.
I think it's adaptable to the U.S. and many major academic centers or other clinical centers that do high volumes of care of atrial fibrillation, particularly for those patients who are eligible for ablation, for example, already have some form of this type of clinic arrangement in place. It may be that it's for a relatively short window of time around the time that they get their ablation, but nonetheless, there are nurses who are parts of teams who are getting people ready for catheter ablation, following them up after the fact, making sure that they're on the appropriate medications, and making sure that they're following up with the appropriate folks in terms of follow-up appointments.
Tomaselli said it might be a challenge to demonstrate that such specialized clinics are cost-effective, but that an expected increase in atrial fibrillation as the population ages might actually ease that problem.
On the one hand, having many more people with the problem makes it more cost efficient, because there clearly is some initial upfront investment that's required in both hardware and people. And if you can extend the reach of providers, whether it's doctors or nurses, to cover more lives, then in fact I think in the long term this may be a less expensive way to do things. On the other hand, there is some upfront cost, and it may be that smaller programs might have some difficulty in affording the infrastructure necessary to do the comprehensive level of care that was provided by this clinic in the Netherlands.
ACC President Dr. David Holmes of the Mayo Clinic also weighed in on the clinic concept.
I think that these type of approaches are going to be healthcare of the future. It's going to be healthcare teams where cardiac care associates or nurse practitioners are going to have a huge role in the chronic management of these patients with chronic diseases. How that will interface with primary care and family medicine and general internal medicine, I think, has yet to be completely sorted out. But I think the healthcare team approach, as you have seen here, is going to be what we're going to see, and I think what we should see, and will result in better care in the future, for sure.
Thielman described his study as a promising first step, but said that further research was needed, particularly regarding cost effectiveness. From New Orleans at the American College of Cardiology meeting, I'm Todd Neal, MedPage Today.